active. So
yes, a lot of response this time. I think without wasting time, we should start.
Dr. Prasad is going to join this one. What time?
I sent a message. Do you want me to ring him up?
Yeah, let me just give a quick ring. Try that. Actually, usually I used to give a call and all, but this time.
No, I sent a message to him yesterday.
Okay.
I am ringing up. Don't worry. Just to see if he's. I feel that it is walking time or something like that. Anyway, we'll start. I think he'll join.
Okay.
Right?
Yep.
I think good evening, everybody. And today we have a very interesting intervention trial, the lacunar intervention trial 2 or LACI 2 in cerebral small vessel vascular disease and isosorbide mononitrate and silastazole treatment intervention. And it will be from JIPMER. And I, along with my chairperson, Dr. Sunil, welcome you all for this exciting journal club. And I hand over to Dr. Sunil for further proceedings and inviting the participants. Also, Dr. Rajeshwari and Dr. Soumya for their deliberations.
Thank you, Dr. Gopi. Nice to see Dr. Nirmal Surya also joining.
Oh, that's nice.
Hi, Dr. Surya, are you around? Hi.
That's nice.
Oh, nice to see you. Right. You are muted. We can't hear you.
Yeah. Good evening, Nirmal.
Yeah, good evening. All the best. I thought being a Indian Stroke Association president-elect, let me hang on to the stroke subsection.
Excellent. And we are pleased and honored.
Thank you.
Thank you so much.
Please carry on.
So today, I think this must be the 8th or 9th. I don't remember.
12th Journal Club.
Yeah.
Total.
Yes. Oh, right, 12. So the Journal Club has been going on quite nicely. Very interesting papers we have been going through. And today it's the turn of JIPMER, and we have two very young neurologists, Dr. Rajeshwari, our associate professor, and Dr. Soumya, our senior resident, are presenting today's Journal Club paper. And as you know, the always lacunar strokes are a very charming group of strokes. Generally, one good thing about them is many of them single attacks, people recover fairly well. But having said that, they have a tendency to accumulate and sometimes silently to ending up with patients with serious psychomotor retardations, subcortical dementias, and also various other disabilities. And how to treat them has always been a little controversial. We have many other groups of strokes where we have specific therapies and specific prophylactic medications. But then when it comes to lacunar stroke, there is a little bit of ambiguity about what's the best way to deal with them. So without taking away your time with the lengthy introduction, I would request Dr. Rajeshwari, who is the moderator of today's program, to start the proceedings.
Sunil, just 1 second, before Dr. Rajeshwari takes, and with your permission, I just want to apprise all the stroke subsection members about the forthcoming subsection elections, and they have to visit the website, and they should apply for both chairperson as well as the convener post. Both are to be to be taken into consideration. So all the members are requested to put up their proposals and nominations on the website. And I'll tell again, once again, in the end of the journal club. So this is a reminder. And Dr. Rajeshwari, please go ahead with them. Thank you. Thank you.
Thank you, sir. There's not much more to add to what Dr. Sunil already said. So lacunar strokes are an area where, we are often left with questioning as to how to exactly go about treating it. Even the guidelines are mostly restricting themselves to management of vascular risk factors. So I thought that this group of trials, so the trial investigators, their idea was different, and they assumed that small vessel disease, cerebral small vessel disease as a group are probably because of endothelial dysfunction. And so in this group of trials, they want to evaluate two potential agents. One is cilostazol and the other is isosorbide mononitrate. Both are known to be endothelial stabilizing agents, and they plan to do this as a series of 3 studies. The LASI one, which has already been published, it was more like a dose escalation study. And the LASI 2 is the study that we are going to be discussing now. And hopefully many of these things that we are going to be discussing and some of the questions that have been left unanswered in LASI 2 will be answered in LASI 3. So with that, I will ask Dr. Soumya to take it away.
Dr. Rajeshwari, I think it's a very well organized sequence of trial, that way quite unique, isn't it?
Yes, sir. I think they have used many trial methodology and trial designs which are not usually seen in the neurology literature. For instance, they have used factorial designs in all their trials. They are also using an adaptive design in the sense that as the series of trials progresses, their sample size is going to be determined by what they are finding. And they have used minimization. So many new things in the trial methodology also they have used that is not very commonly used in neurology literature.
Right. So shall we start with the
Yeah, Dr. Soumya, you can start, I think.
Yes. Good evening, sir. I'm Dr. I'm senior resident from Department of Neurology, JIPMA. Today, I'm going to discuss an article from JAMA Neurology, which is titled Isosorbate Mononitrate and Cilostazol Treatment in Patients with Symptomatic Cerebral Small Vessel Disease. This is lacunar intervention trial 2, which is a randomized control trial. The author of this article is Giovanna M. Wadla.
Soumya, are you sharing slides? Because we are not able to see.
Yes, ma'am. My screen slide share is on.
Ma'am, reshare your slide deck.
You'll have to
Select
do
on
the
reshare.
share again. Share it once again.
Click on new share button. Hello. Can you see the new share button?
1 minute.
What is the button called? New share.
New
Right?
share, yeah.
Sir, good evening, sir. I just reminder for the journal club.
Soumya, are you able to see that new share button?
Yes, new share I'm not able to see, sir.
So do one thing, close your PowerPoint.
Yes.
Yeah.
Yes, ma'am.
Yeah. And go to the Zoom and then share your screen.
The other one is the share screen is there. That won't work. Huh?
Okay, sir. Right, sir. Whenever you
There is a start screen.
Stat screen.
Screen, click on screen. Yeah.
Got it. Yes.
Yeah, now it has come. I think you have to
No,
go
it's-
back to the first slide again.
Dr. Sunil, I got a message from Dr. Prasad. He's with Health Minister in Ranchi. He said he'll join in between and give his comments.
All right. Yeah, this evenings many a time.
And put it on slideshow mode. Yeah.
Yeah,
Yeah,
that's good.
okay. Ma'am.
Right, nice.
Okay.
Carry on.
I'll start over. I'm
Yes,
Dr.
yes.
I'm Dr. Soumya from President. I'm going to present a journal from JAMA Neurology titled Isosorbate Mononitrate and Cilastazole Treatment in Patients with Symptomatic Cerebral Small Vessel Disease. This is the lacunar intervention trial 2. The author of this article is Joanna M. Wardla. She is from Edinburgh University. So a little background about lacunar stroke. These are subcortical infarcts less than 1.5 centimeters caused due to occlusion of perforator vessels. This can be due to multiple causes like atherosclerotic disease, cardioembolic, endothelial dysfunction, and lipohyalinosis. So this accounts for around 25% of the total strokes. And in India, it accounts for around 20% of the strokes occurring. And there is a 4 to 11% risk for recurrence of stroke. So, and these have a risk of neurological deterioration for around 23 to 41%. The management guidelines for lacunar stroke, according to AHA guidelines, says that in early period, which is less than 7 days, DAPT, comprising of aspirin and clopidogrel, is indicated to be continued for around 21 to 90 days. And for secondary prevention, aspirin is clopidogrel is more preferred than aspirin as per CAPTI trial. And aspirin plus dipyridamole is more effective, considered to be more effective as per ESPS2 trials. Here the usefulness of cilastazole is uncertain. And guidelines recommend that to have a hypertension, to control a systemic hypertension, to have a target less than 130/80, and some trials recommend an intensive control of less than 120 systolic blood pressure. So with these blood pressure controls, we could achieve a reduction in recurrent stroke with a relative risk of 0.78. And management also includes control of other risk factors, which are diabetes mellitus, hyperlipidemia, lifestyle changes. And there is also a role for rivaroxaban, which is questionable. So when we look at the long-term outcomes of lacunar stroke, it is directly related to the white matter disease burden. So these patients tend to have cognitive and functional deterioration, and there is a recurrence of stroke, and there is also a increased risk of mortality, which is all more in patients with a higher burden of white matter disease. And going into the drugs which are studied in this trial, the first one is isosorbate mononitrate, which is a long-acting nitrate, which acts by activation through cytochrome P450 enzyme, release of nitric oxide, and it activates GTP, and which activates cyclic GMP, thus lowering intracellular calcium and causing vasodilatation. So the mechanism of action, its actions would be promoting ischemic deconditioning, angiogenesis after ischemic stroke, being a neuroprotective under ischemia and reperfusion, maintaining and restoring penumbral and collateral blood flow, and promoting neurogenesis. Regarding stroke nitrates, the use of nitrates in stroke. Previously, trials have been conducted, and it shows that there isn't much benefit of nitrates in acute stroke. And there is a trial, RIGHT-2, which in which transdermal glycerol trinitrate was used versus sham group, and there wasn't much of improvement in the functional outcome. And going on to the second drug, which is cilastazole, which is actually a phosphodiesterase 3 inhibitor. This drug acts by increasing the cyclic AMP, thereby producing the following effects like endothelial repair, endothelial re-endothelialization, anti-proliferative effect for smooth muscle cells, and promotion of anti-inflammatory effect. See, looking at celestazole in stroke, previous trials have shown that celestazole has a significant benefit, like reducing the recurrence in ischemic stroke, hemorrhagic stroke, reduction in mortality, and reduction in bleeding when compared to placebo, aspirin, or clopidogrel. So these benefits are more when given in long term, like for a longer period, like more than 6 months. Going on to LASI-1. LASI-1 is a tolerability and safety trial for the pharmacological effects of celestazole and isosorbate mononitrate. It was also an RCT. This preceded LASI-2. So it was a phase 2A partial factorial study design with the study methods included. Patients were allocated to isosorbate mononitrate and or celestazole for 11 weeks with dose escalation. So the tolerability, safety, parameters like tolerability, safety, blood pressure, pulse wave velocity, platelet function, and MRI were assessed. So the results were, out of 57 patients included, 87% were able to tolerate over half the dose. Headache and palpitations were initially increased, then declined. It was pulse rate and platelet count was also increased in these patients. There was no between group difference in BP, pulse wave velocity, hemoglobin, or platelet function. And significant white matter reduction, white matter hyperintensity was noticed with the celestazole group versus the no celestazole group. So with this introduction on LASI-1, we can go on to LASI-2, which was initiated with the main objectives to determine if celestazole and isosorbate mononitrate alone or together are tolerated at target dose for 1 year. And this was also done to provide feasibility and safety and efficacy so that this would provide information for a larger phase 3 trial. So LASI-2 is a phase 2B trial. It is a randomized control trial, investigator-led, open label, blinded endpoint trial. It had a 2x2 factorial trial, 2x2 factorial study design. This is based on the fact that isosorbate mononitrate and celestazole had complementary modes of action and no adverse interactions. Patients were randomized to treatment with and without isosorbate mononitrate and with and without celestazole in 1:1 ratio. So this trial was conducted in 26 stroke specialist hospitals in UK from February 5, 2018 to May 31, 2021. And the randomization techniques used was it was a web-based randomization, and minimization technique was used to ensure that participants were equally distributed among the groups. So minimization was done based on age, sex, NIHSS, MRS, parameters like systolic blood pressure, smoking status, time after stroke, and years of education. So this is an open label trial. The only people blinded were the central follow-up staff, central image assessors, statisticians, and LASI-2 trial steering committee. The inclusion criteria for this patients was based on imaging, MRI, and CT findings with the infarct or white matter changes were included. But clinical lacunar stroke syndrome was also included, even though imaging was negative, provided there was no competing pathology there. And all these patients were more than 30 years old, and all these patients had a MRS less than 2. And all patients who had a significantly higher MRS requiring assistance with the activities of daily living, who had dementia, who had active cardiac disease, hypotension, systemic illness, or any other end-stage disease were excluded. So the sample size was calculated based on the assumptions that 75% of the patients would take the trial medication in at least half the dose for up to 1 year. So from based on LASI-1. So they assumed that the mean annual event rates would be 2% with an upper limit of 4%. Assuming that the absolute risk of death, including fatal hemorrhage, will not exceed 4% per year on trial drug versus no trial drug, and there will not be any increase in bleeding or ischemic small vessel disease significantly on MRI. The LASI-2 trial sample size was estimated around 400. So these patients after randomization received isosorbate mononitrate silastazole and the combination of isosorbate mononitrate plus silastazole or no drug. So the participants were started on these drugs the day after randomization, and the dosage was slowly escalated to the maximum tolerated dose by around 4 weeks. So these patients also received guideline prescribed stroke prevention. At the end of the study, the outcomes were primary outcomes. The primary outcome measures were to have for 95% of the patient population retained for follow-up at the end of 1 year. And the secondary outcomes assessed was tolerability, safety, and efficacy. Tolerability being 75% of the patients should be able to tolerate at least half the dose up to 1 year after randomization. And safety being any systemic or intracranial bleeding, any risk of death, which included fatal hemorrhage, or any new ischemic or hemorrhagic lesions on the MRI, or any increase in small vessel lesions at the end of 1 year in MRI. And the efficacy assessed was a combined rate of recurrent stroke, MI, death, mild cognitive impairment, dependency, or new stroke lesions at the scanning or on scanning at the end of 1 year, to allow any detection of modest but clinically important reduction in poor outcomes in a phase 3 trial, and measurement of health economic measures, which included health utility scores and visual analog scores at the end of 12 months. They also assessed individual event rates reduction in stroke, TIA, myocardial ischemia, cognitive impairment, and dementia. So the method was, initially the patients were screened for eligibility. Once the screening was completed, the first line baseline visit imaging was obtained, baseline blood work was obtained, baseline cognitive tests were obtained. So these patients, and at the end of followed up for a period of 12 months, and at the end of 12 months, again cognitive assessments and imaging scorings were obtained, and data regarding quality of life was also obtained. So the primary outcome was and the secondary outcomes, all analysis was based on intent, and the safety outcomes were assessed by logistic regression, and the efficacy outcomes were assessed using Cox proportional hazard regression, and ordinal logistic regression was used for ordinal outcomes like MRS, and they haven't done any adjustment for multiple testing. This is a modified curve diagram which included 363 participants who had initially consented, and out of the 363 participants, 91 were allocated to a combination of silastazole plus isosorbate mononitrate, 90 were allotted to isosorbate mononitrate, 91 were allotted to silastazole, and 91 were allotted to neither one. So these patients were followed up for a period of 12 months, where 88 patients were retained in the first group, and 88 patients were retained in the isosorbate mononitrate group, and 89 patients with data were retained in the cilostazol group, and 90 patients were retained in the group which received none of the drugs. So going on to the baseline characteristics, baseline characteristics analyzed here includes age, sex, MRS score, onset of stroke to randomization period, time period, completed education status, whether there is any smoking history or not, or current smoker or not, comorbidities like diabetes, hypertension, hyperlipidemia, atrial fibrillation, carotid stenosis, previous stroke or previous TIA, the use of medications, antiplatelets, antihypertensive statins, the blood pressure recordings, so the NIHS score, cognitive MoCA scores, trial making test, and the imaging findings, the white matter disease burden, and if the patient had any contraindication to either of the drugs. So among these baseline characteristics, we can see that 2/3 of the child patients were men, and all of these baseline characters were equally distributed. But the trial included patients who are like more 2/3 of the patients included were men, and we can see that these were like these patients were the random time period within which these patients were included was 79 days from the onset of stroke, and most of these patients had a very minimal NIHS score, and these patients had a like better MoCA scores. Like they were not very much cognitively impaired, and we can see that around 2/3 of the patient had a significant white matter disease burden. So moving on to the primary outcome, at 1 year end follow-up, the patients, we could see that 358 patients were retained, and 257 out of the 272 patients who were taking the medication were taking more than or equal to 50% of the allocated drug dose. Coming to the safety parameters, the isosorbate mononitrate patients had headache, cilostazol patients had loose stools, and the group which received both the medications had both headache and loose stools. But there was no increased risk of bleeding noted in any of these groups. We can see that the study period was done during the COVID pandemic, which had significantly affected the recruitment and the follow-up. So they were not able to do the certain things like MRI at the end of 12 months and trial B test at the end of 12 months. So going on to the secondary outcomes, looking at the efficacy, isosorbate mononitrate in the group which received isosorbate mononitrate without isosorbate and versus without isosorbate mononitrate, we can see that there is a reduction in stroke or transient ischemic attack. There is a reduction in recurrent stroke or TIA. There is an improvement in quality of life. There is an improvement in clinical outcome and stroke impact scale outcome, which is also reflected in the forest plot. And in the efficacy of the group taking cilostazol, this is no cilostazol, we can say that there is some improvement in the MRS. Other than that, we cannot see any other significant improvement. Whereas in the group which received both the medications, we can see that there is an improvement in the composite outcome. There is an improvement in the dependence in the MRS. There is an improvement in the quality of life. There is an improvement in the clinical outcome. There is an improvement in the stroke impact scale outcome, which is also reflected in the forest plot. So, with respect to cognition and mood, we can see that there is some benefit in the group which received isosorbate mononitrate, but there is also some benefit in the in the group which received the combination of isosorbate mononitrate and cilostazole, which can be seen in this ordinal adjusted analysis, which shows that all the patients who received the medication, any medication, had an improvement in cognition versus the group which didn't receive the outcome, whereas the maximum benefit was in the group which received the combination of both the medications. So going on to the discussion, we can see that ISMN and cilostazole both are well tolerated and safe. So they may improve the vascular, functional, and cognitive outcomes by acting through a mechanism of endothelial stabilization. And also we can see that the type of patients included in this trial are like typical of the patients who are likely to have a lacunar ischemic stroke. They are younger, there are more men, fewer embolic sources, and a lower dependence rate, lower death rate, with a higher cognitive burden. So the limitations in this trial would be the lacunar all clinical lacunar syndromes were also included in this trial. So they may have included also some stroke mimics. We do not have a placebo in this study, which can also be considered as a limitation. And the COVID-19 pandemic during the time period during which the study was conducted has definitely affected the recruitment. And there is also a 10.9% loss of follow-up. And when comparison of isosorbate mononitrate and cilostazole combination, the study is versus the no drug, this comparison is considered to be underpowered. And the factorial study design can also be considered as a limitation. And those with a higher MRS were excluded. So we do not know what kind of impact that would have caused if those patients were also included in this trial. And we did not have much data regarding the race and ethnicity. So we do not know if that has affected the outcome of the study. So discussing the strength of this study, they have used a web-based randomization and minimization technique. Again, factorial design can also be considered as a strength. They are saying that all these effects were achieved without any changes in the systemic blood pressure. And the composite and global analysis here is compensating for low individual recurrent vascular events and dependence rates. And also it also includes clinical endpoints, including cognition. So all these can consider to be the strength of this trial. So in conclusion, we can say that based on LASI-2, we can say that isosorbate mononitrate and cilostazole both are well tolerated and safe. So these agents may reduce recurrent stroke, dependence, and cognitive impairment after lacunar stroke, and they could also prevent other adverse outcomes in cerebral small vessel disease. So we do not. So further evidence can be obtained with the larger phase 3 trial. So moving on to the critical appraisal. Here, this trial included typical patients with lacunar stroke in the chronic phase, who did not have any significant motor or cognitive disability. So the intervention they received was either ISMN or cilostazole or both, which wasn't compared to a placebo. There were no drugs for comparison. The primary outcome assessed was proportion retained on follow-up, and the secondary outcome assessed was ischemic stroke, vascular events, and cognition, which was done over a time period of 12 months. So this cohort is very much similar to what is expected of a lacunar stroke population. So there isn't much of a selection bias. But in the previous studies had used participants who are high risk for stroke and who had a much higher disability. But this did not include those kind of participants. So we do not know if those patients were included in this study, whether this drug would have been of any use in them or not, or whether it would have affected the outcome of the trial in which direction is uncertain. Patients from multiple centers in UK have been included, but we do not have any data regarding the race or ethnicity. So we do not know if race is a factor which is affecting the outcome of this trial. Whether a certain group of patients aren't or are responsive to the study drug used in this trial. And 1/3 of the patient have no MRI findings. So we do not know about the disease burden in those patients, the white matter disease burden in those patients. And we do not know how that has affected the outcome of the study. With regards to randomization, web-based randomization with minimization has been used to assure that the distribution was the study population were evenly distributed among the groups. And with regard to measurement bias, this is an open label study. The assessors were blinded with nearly 10% attrition. That might have affected the outcome of the study. The estimated population size was 400, but this was not achieved, and no explanation regarding why it was not achieved was given. The factorial study design has interactions. We had identified interactions with both active groups behaving differently. And this further underpowers the study. So with regards to adherence to the drug, only 2/3 have self-reported adherence. So we do not know whether the drug has produced the effect or it is some other factors which have given the outcome of the trial. So with the use of composite outcomes, it is difficult to interpret the exact outcome of the trial. So all of these are likely to underestimate the effect size. So the patients had received guideline-based treatment but we do not have any data regarding the proportion of what proportion of population were adherent and what proportion received the targets, recommended targets, and also there is a lot of data regarding dietary nitrates and cardiovascular outcomes. So the dietary nitrates have not been considered in this study, and chronic nitrate therapy there is a lot of evidence to prove that there is endothelial toxicity and there is no improvement in outcome with chronic nitrate therapy in cardiovascular literature, but the study outcomes are contrary to this. And also nitrates historically have been used as an antihypertensive, but here in this trial they haven't caused any BP reduction. So we do not know why there is no BP reduction with the nitrates in this study. And there is a lot of literature which supports reduction recurrent stroke with cilostazol, but here this effect is not seen. We do not know whether it is due to the race effect or whether it is due to the type of population, exclusion of a certain population who may actually benefit from this drug. And there is also literature supporting that chronic dual antiplatelet therapy with dipyridamole is beneficial in stroke reduction in recurrence, whereas cilostazol is from the same family of drug, but these effects are not seen here, and we do not know the exact cause why it is not seen. So most of the patients have received guideline mandated dual antiplatelet therapy. but so we do not know whether this effect that we are seeing is due to the DAPT or whether it is due to the child medication. So in summary, we can say that lacunar strokes, here this study has included lacunar strokes with good outcomes. And the study is underpowered due to its study design. And it has included multiple co-interventions with little details. And the direction of effect is expected is different from what is expected actually. There's no BP reduction with nitrates. There is no effect of silostazole, and we do not know what exactly is the reason causing this. And also other confounders like dietary nitrates. We do not have much data regarding that. So in conclusion, we can see that it had included a population of 251 men, 112 women from trial done in 26 hospitals, including 363 patients with a primary outcome defined as more than 95% of patients being retained at the end of 1 year, with the primary outcomes of they were able to retain 95% of the patients with good adherence and with no safety concerns. So, thank you.
Thank you, Dr. Soumya. And before we ask Dr. Rajeshwari to come, there is one question which is raised, whether other antiplatelets were used in this study. I mean, continued or not. That's by Dr. M.K.
Yes,
Roy.
sir. Yes, sir. Yes, sir. Other antiplatelets, all these patients received a guideline mandated dual antiplatelet therapy. So if they were in the within the 90 days, they had received guideline mandated DAPT. Yes, they continued. All those patients on aspirin, they were continued on the antiplatelets.
And before I invite all the seniors who are attending this, Dr. J.M.K. Murthy I saw, and they want to ask any questions about the presentation before Dr. Rajeshwari and Dr. Sunil will give their expert comments. So may I ask others to join? Dr. Asmita, will you open the forum for others to join, so they can ask questions? Asmita, are you there? Are you opened? For others to unmute and ask their questions, or you can put it in the chat box. If there are no questions forthcoming, I request Dr. Asmita or Dr. Rajeshwari to go ahead with her conclusion, followed by Dr. Sunil Narayan for his expert comments.
Actually, we picked this trial for two important reasons. One was both isosorbide mononitrate and silostazole are actually fairly cheap drugs, and they have a long history of usage. Silostazole has been approved and is being widely used for peripheral vascular disease. So silostazole, in a series of trials, mostly from Asian populations, showed in the forest plot, have all shown to be beneficial in patients for secondary prevention of stroke. And in fact, the Japanese stroke guidelines actually recommend use of silostazole as a drug for secondary prevention of stroke. But most of the Western literature, including the Western guideline makers, they feel that this might be a race effect, because all of these were based on Asian population, that we need more information. And so they have actually given silostazole as uncertain evidence, and they have not recommended the use of silostazole. And it is heartening to note that these people have taken it upon themselves to actually perform a trial and to establish effect of silostazole. But what we did find in LACI2 was that silostazole did not show as much benefit in the study. Of course, this is all secondary analysis, secondary outcomes, and they're underpowered study. But even then, there wasn't even a tendency compared to, not even like isosorbide mononitrate. So in reduction in recurrent ischemic strokes. So we found that, but it reduced dependency. So I do not know what is the difference in the type, whether it is a difference in the type of small vessel disease or some other underlying pathologic factors that are different between the Asian races, or there is some other confounding effect. And the other drug, isosorbide mononitrate, again, actually in the cardiovascular literature, a lot of nitrates have been used as anti-anginal agents for a long time now. And there is a lot of evidence to show that chronic nitrate therapy produces tolerance. It induces nitrate toxicity. And there is actually some evidence to show that chronic nitrate therapy may actually be detrimental in these patients. But we are seeing that in stroke, at least in this particular LASI-TRU, the patients seem to be behaving differently. So is it unique to the cerebral vasculature, cerebral small vessel disease? I think these are all very interesting questions that we need to think about. And I hopefully LASI-3 and much more will provide much more light on all of these things.
Rajeshri, before Sunil, I heard your comments, and I wanted to say that this is a phase 2 trial, and the primary outcome is here only feasibility because of the side effects of the drugs. Whether
Yes.
isosorbide will cause headache or the silastol causes loose stools, the efficacy things will not come into this, and that may be a hypothesis generation whether we should
Yes,
work
yes.
out or not. And this is a phase 2 trial. This is not a
Yes.
phase 3 efficacy trial. So
True.
I think all these questions remain unanswered for us. The only thing
Yes.
is that yes, there is a scope for further studies be using both these drugs, and which is very exciting to know that we can do something for these unfortunate patients. Sunil, your
Indeed.
comment, please.
Yeah, before I go in, there are a couple of questions. One question, yeah, that is if dipyridamole and silastazole are of same group, why to use both of them? There is one study.
Can I answer that, sir?
Yes.
Yeah,
yes.
please.
Actually, both dipyridamole and silastazole are phosphodiesterase inhibitors, and dipyridamole is PDE5 and silastazole is PDE3. So dipyridamole, it actually acts via cyclic GMP, whereas silastazole acts, like she said, on cyclic AMP. So there are subtle differences in the way they provide their action. So it is felt that these subtle differences may be what is accounting for the different outcome or for the differences in their behavior of these stroke patients. And further, I think from the cardiovascular literature, from the cardiology literature, there is evidence to show that a combination of PDE5 like dipyridamole and mononitrates and nitrates is not a good combination. They can present with acute hypotension. And that may also be one of the reasons why the study authors wanted to test out silastazole. I don't know. These are questions that are unanswered.
Right. Professor Murthy, you have any comments, sir? Professor JMK Murthy?
I think there are no comments, but we can ask them to join anytime to give
Yes,
some
yes,
other
yes.
comments. Some other questions have come. I think Mrinal Kantirai says, please unmute. I have a comment. Yes, I think Asmita, please unmute Dr. Roy. And silastazole dipyridamole study should go. Actually, this is a study of phase 2, and it is only a feasibility study. It's not efficacy or effectiveness study. So there will be some hypothesis, some more studies coming up. I think Rajeshri can comment more on these questions.
No, I agree with you, sir, because this is only hypothesis generating. But the fact of the matter is silastazole also has got multiple meta-analysis. I think in the last 2 years, there are so many papers that have come out, so many systematic reviews, including one by the authors themselves on cognitive decline for silastazole. And almost all the studies across the board and all the systematic reviews seem to show that silastazole is beneficial. And as far as dipyridamole is there, I think dipyridamole and dipyridamole aspirin combination, that ESPS2, and that has been much discussed. So what exactly is the difference between the two drugs, and why do they behave differently? Is it race specific? Is it ethnicity specific? Or is there something else that is going on with the cerebral small vessel? I do not know.
Okay. One is silastazole versus dipyridamole study should go. That is by Vasudeva. He says that, yes, that is not in your hands. Somebody has to design and do the study. If dipyridamole and
Girish,
silastazole have same group, why to use both? So actually, that is not the primary question of this trial. I think, sir, you can ask. You can answer this question.
Professor Prasad, I think, sir, your comment is there. Would you like to come on screen? Smita, can
sir,
you
please come, sir. Answer live. Yes, sir. You are. Would you like to answer the? Dr. Prasad, you can join. I think there was some connection problem.
Hello.
Yeah. Aswita, see if Dr. Prasad can be taken
Yeah.
online.
Now he is in finalist.
Yeah, can you hear me now?
Yes, sir. Yes,
yes, sir. We can see you also.
I think Dr. Gorti has already pointed out that this is a phase 2 study, so nothing conclusive can be achieved from this. However, one interesting methodological issue is that they used composite outcomes, and I think this is an opportunity to learn about composite outcomes. Composite outcomes are used to enhance power of the study, but it has a downside. Downside is that clinically important outcomes are mixed up with clinically less meaningful outcomes. And I think I didn't go through the whole study and the presentation, but I think the presenter made a comment that subjective outcomes are also included in the composite outcome, which is not good. Each outcome in the composite should be clinically equally meaningful. That is the ideal composite. And secondly, direction of effect must be checked in each component of the outcome, and it should be in the same direction. Then only composite outcome makes sense. So I don't know whether direction of effect was similar across all the components or not. In any
No, sir,
case,
it wasn't. In this study, it was not same. There was some were in favor, some had no effect like that.
so actually they should present result for each component and ideally draw what we call something like forest plot so that people can see what is the direction, even though confidence interval will be crossing the line of no effect, but that's fine. But at least one can see the direction. And obviously they didn't do it because it is phase 2 study. It was not powered enough to clearly show anything. But what I mean to say is that we can use it as an example to teach composite. What is ideal composite? Ideal composite should have each component clinically equally meaningful, and then only, and at least the direction of effect should be similar. These are the points I wanted to make. Thank you.
Thank you, sir. Thank you. And
Sure.
I think wonderful points which you made, and stress on the importance of outcome measures. Good, sir. Rajeshwari, Dr. Rajeshwari, what do you want to say? Anything you want to say?
No, sir.
Right. Okay. Sunil, anything?
Dr. Girish has a question. Dr. Girish, you want to come on mic, or would you like to answer?
I can read out the question for him.
Yeah.
Monoxidase inhibitor, MOA
I think
drugs
I think no. I think he just put a mechanism of action
of drugs.
And lacunar stroke, whether matching duration for recurrence.
Girish, I think you should come on and ask
Yeah.
the question. Unmute yourself. We are not able to follow the question.
Second part is a little confusing.
Can I have my comment now, sir? If
Yes,
you allow
yes.
me, Dr. Rai speaking.
Yes, yes.
So only it's an excellent presentation. I should give the credit, full credit to the presenter. And Rajeshwari has nicely explained the drawbacks of the study too. But I have got a question also. I want to learn from you that if you use the silestazole for the peripheral vascular disease, it is usually the large vessels in the peripheral vascular disease, not the small vessel of the peripheral vascular disease. This is number one. And number two, regarding this other group drug like your isosorbate mononitrate or any other groups of nitrates, if you use it for a prolonged period of time, there is every possibility of tachyphylaxis. Your
That has
comment
been,
is-
no, that has
Rajeshwari,
been addressed by Rajeshwari. She said there is a
Rajeshwari,
tachyphylaxis period and that has to be taken care of. And moreover, the primary endpoint of the study is not the efficacy. It is the feasibility of the study, whether patients can tolerate the drugs. So I think we should keep that in mind. Dr. Rajeshwari, your comments.
I have only one more thing to add. Apart from tolerance, I think there is also a possibility of direct endothelial toxicity. I mean, and I think that is worrisome because we are talking about chronic lacunar stroke patients and we are thinking of giving them over a long time, these nitrates. So there is, I don't know if the cerebral small vessel disease will behave differently from other areas, but that is something to be kept in mind when we are designing, when we are thinking about the interpretation of the larger phase 3 trials, because this is from cardiovascular literature over decades, which may not again be captured in the phase 3 trial.
One thing exciting about this study is the cognitive function, which we are going to test out 12 months. That's very exciting. And I think we should have more trials of this nature to define vascular dementia with lacunar stroke. Sunil, what do you feel?
Yes. Quite a what do you call the little it's quite a complex study. A lot of things to learn from the study. The main merit I would like to give to the study is the way the whole planning has been done to try to look at a problem which remains unanswered. That is, what is the best line of secondary prevention for lacunar strokes? Can we improve upon from whatever we have been doing for the other types of strokes in this unique syndrome? And they really put their heart into it. They have organized it as 3 phases, phase trials, and going the right direction. Of course, the pandemic hit it and they couldn't reach the primary sample size, but I think the results, the primary outcome result of studying the feasibility and safety parts, etc., has been answered by this study. The secondary outcomes are all always secondary outcomes. You need a properly powered study, probably at a phase 3 level, where we can look at those things. We did find out the issues and problems in this study, which will give good guidelines. So this is the way to ideally go about answering questions in a very systematic way.
Sunil, I think that's correct. Rajeshwari and Sunil, what I want is a cross-sectional study to assess the cognitive impairment in lacunar stroke and introduce the treatment and see at 12 months what is the improvement. That's going to be our phase 3. If at all we as a stroke subsection want to plan a study, we should do that.
Yeah, I mean, it has given a lot of food for thought, and many offshoots could come out from the results of this phase 2 trial, especially from the cognitive outcomes, and the mechanism of actions are very interesting and unique. And there are problems with, of course, other exposures to nitrate in our diets, etc. So how to tackle that is a very complex question. I don't know how to answer it. We will really need some very special way of doing that, or maybe even we'll have to even ignore it. I don't know. That may not be the right answer.
All of us agree that vascular dementia is a problem which we have to tackle. We have to define our ways and means to tackle it. I think I invite comments from all attendees, whoever wants to say something before we end.
Dr. Anand is there. Dr. Anand has some interest in
I think
small vessel disease. Anand Vaishnav, are you able to join us?
no, somebody asked the role of low molar heparin initially in cardioembolic versus dual antiplatelets. That's what they wanted to know. But this is beyond the scope of this article, but you can answer. Role of low molar heparin initially in cardioembolic versus dual antiplatelets. Thanks. And as far as I know, the dual antiplatelets are given only for minor TIAs, as a minor strokes and TIAs for 3 weeks. That's the only recommendation. And there's a trial going on where dual antiplatelets are given for 1 year in intracranial stenosis. That's the 2 indications which we are using. For all the cardioembolic strokes, yes, we give low molar heparin and to prevent further strokes. So, Sunil, your comments.
Yeah, I mean, the context in case of lacunar strokes is not very clear to me. I think the only situation where we use low molecular weight heparin is when people get this, sometimes when you get this lacunar TIAs, crescendo TIAs in lacunar strokes, sometimes we do put them on low molecular weight heparin, but that's again not with I mean, it's very difficult to produce evidence in such case of fairly uncommon situations. But dual antiplatelets, of course, we have very clear guidelines, and the utility beyond 3 months up to 1 year. The stenosis trial in India is trying to answer it, but that is not specifically for TIAs, but for intracranial small vessel disease. So that's what I would like to comment about this specific question.
So I think we had a wonderful session, and it's time for us to wind up also. And before I end, I always request the participants to think about the forthcoming elections, and please do visit the website, and please put your nominations for chairperson as well as the convener of this thing. Dr. Rajeshri and Dr. Soumya have done an excellent, and today's presence, the attendance is a member. 55 people have attended. That's a record for us, and I think it speaks volumes of your talk and your selection of the topic. And Sunil, I think if you have no other comments, we can wind up.
Yeah, just thank everyone for.
I really thank Dr. Soumya and Dr. Rajeshri for their excellent work about these cases, and Dr. Prasad, of course, for his exceptional comments, and we have to look at the.
And also Dr. Gorti for his very active engagement, and also the convening the programs in a very effective way, and for all the announcements on time, and the dissemination of the information. That's also responsible for it. So thank you.
Sunil, friends, we want to highlight the forthcoming July 27, 29th stroke conference. Please make it a point to attend, and we'll be sending the invites in the next week. And there is an abstract submission deadline. You can put up your papers. It's going to be in Bharati Vidyapit Pune auditorium, and all are requested to attend in grand numbers. And that's all with that. I think
only around 7 weeks left, but that's good enough time for all of us to.
We have a galaxy of speakers who are coming to attend this conference, and all the stroke specialists in India are visiting. You name them, they are there.
And a very important topic. And there is also, as in the last time, a very special session on the research methodology, again spearheaded by Professor Kamisha Prasad. And the clinical topics covered do cover all the.
Sunil, I wanted to emphasize that we have based this program on the knowledge, attitude, and practices survey which we have done, which is going to publish in Journal of Stroke Medicine, and we selected those topics which the individuals felt that they required to fill up that communication gap. So those topics were included.
And we are going to have a very special session on the cerebral hemodynamics
Yes.
of stroke,
Yes.
which I think we all will find it quite interesting, not very often covered in such meetings. So it's going to be a very unique conference at Pune, and look forward to seeing all of you at Pune. And Dr. Goti's team is all completely geared up to
Yes. And
have
the Society of Pune Neurology are backing us. That's a big
yes,
thing.
entire
They are
society.
really doing a great job. So with this, a few comments, I take your permission to wind up the session.
Dr. Anand Vaishnav, come on the screen. Dr. Anand, you would like to make some comments?
No, I think all of you have, all of you have mentioned it. I think I'm so happy that after SPS 3, this is the only trial which is going on to do a phase 3 study in lacunar. So I think Dr. Gorti mentioned, I think I'm so happy about it. I know this was just a safety study. And I think, Dr. Rajeshri, thank you. I think, I was at the ISC 23 when this was presented, and it's good out in print. And I hope, see, in this whole world of thrombolysis and thrombectomy, I think lacunar strokes and cognitive decline has unfortunately, been thrown away. So I think let's hope we get a phase 3. Thank you. Thank you for presenting it. I'm so happy.
And I'm so happy that everybody enjoyed this. Sunil, with your permission, shall I close? Shall I leave? Good night,
yes,
everybody. Good night, everybody.
Thank you, Dr. Soumya, Dr. Rajeshri.
Dr. Soumya and Rajeshri, a wonderful job. Excellent.
Lovely.
Thank you all.
Bye. Good night.
Good night.